Welcome everybody. Thank you for joining us for another APSAD Insight webinar. My name's Jim Hunt. I'm one of the nurse educators here at Insight. I think today is going to be an interesting presentation, so thank you for joining us. Before we begin, I'd like to acknowledge the traditional owners and custodians of the land on which we're meeting today, and I'd like to pay my respects to elders past, present and future. And I'd like to extend that welcome and respect to any Aboriginal or Torres Strait Islanders that might be joining us in webinar land. So thank you and welcome. As I said, I think today's going to be an interesting one. We've got a couple of people that Insight have worked with before. Certainly one of the names, Michelle Combo, maybe somebody that you recognise. She's presented a webinar here in the past and also done some other work for Insight. So we're very grateful for their time today. So Leigh-Anne Pokino is the lady that's going to do the main presentation. She's a primary healthcare worker in the Indigenous community and has done this for about 15 years in various roles. And as I say, she's joined by Michelle Combo, who's a psychologist and team leader. They're both from the Southern Queensland Centre of Excellence in Aboriginal and Torres Strait Islander primary healthcare. And they're going to be presenting on empowering strong families and the things that they found out whilst carrying out some research in smoking cessation and the links that they found in relation to trauma. So without any further ado, I'd like to welcome Leigh-Anne Pokino to present the webinar today. So thank you.
Thank you. I'm just figuring out the technology. Okay, so good morning, everyone. I just wanted to acknowledge that I'm a guest here in Jagera country where we're sitting in Inala. I'm actually a Gamillara woman from northwest New South Wales. I've been living and working up in Brisbane now for pretty much half my life, so been here for quite a while. And my name is Michelle Combo, so I've done a couple of talks with Insight before, mostly just from the perspective of an Aboriginal psychologist working primarily in mental health and specifically in trauma. And my intention today is just to try and support Leigh-Anne with presenting what we've found with the Empowering Strong Families program out here at Inala.
Cool, thank you, Michelle. So yeah, I guess my connection to Inala, I'd like to acknowledge the Jagera people and the lands on which we are on. I'm a visitor on this land and I acknowledge that I'm originally from New Zealand and grew up in Brisbane, but worked out here at Inala since 2004. So I'm very honoured being able to work in this space. And I don't think I could go anywhere else. Inala is, where I feel comfortable at, and been working in Indigenous health for 15, 16 years. So feeling my age. But today what we want to do is present about a research project we did Empowering Strong Families 4077 and how this research was able to be implemented as core business within the Centre of Excellence. So as we know, smoking during pregnancy can be very harmful for mother and baby. But I guess realising that within an Indigenous complex, it's a lot more challenging to get smoking on the agenda, and you've got to understand the historical context as well as all the trauma that's involved, not just focusing solely on smoking. So these are some quotes done by the case managers. I'll just read the first one. I don't think you can address any issue like smoking without addressing the social and emotional well-being. But if you can, get them a house, get them stable environment, get them food, get them Centrelink payments, you're halfway there to helping the smoking. And if we can catch them when they're young, then they've got a better chance of living a healthier lifestyle. And I think that was the real key, is often when I worked with these women, smoking was never a first priority. There was a lot of other complex issues that we had to address before we could even get smoking on the agenda. And I think we've got to acknowledge that when we're working in an Indigenous context, there's a lot of complex trauma. We've got Centrelink, housing, domestic violence, drug and alcohol abuse, a lot of all that kind of comes before smoking does. So we've really got to address the stresses, I guess, and try and support behaviours to change smoking. So when we started the Empowering Strong Families, we actually received a grant from the Australian government, Tackling Indigenous Smoking Innovation Grant, and the research was conducted from November 2016 and we recruited until January 2018. So there was only a small time frame we had to do recruitment, but the actual program and the research finished in June 2018. So what we did, we had an advisory group, and this group of Aboriginal and Torres Strait Islander women really were the leaders, and they were the ones who told us, you know, what they wanted, how they wanted to see the program run out. And they were the ones that actually came up with the name Empowering Strong Families 4077. And I think it's really simplifies how Inala community is, that they are, this is, you know, a strong community, and it's about empowering our families. They're already strong, but it's about what can we do to empower them more. And 4077 is the postcode of Inala, which is, you know, people are proud to be from Inala. It's a beautiful community. So that's where the name came from. So we would monthly try and meet with this advisory group and feedback what we were doing, and really ensure that they had the power. So recruitment was between the ages of 14 and 30 years of age. So the criteria really was that the baby had to be Aboriginal and or Torres Strait. So the mum could be non-Indigenous and the father could be Aboriginal, or vice versa. We supported the significant other, that was optional. And when we refer to significant other, we mean whether it was the father of the baby, it could have been the auntie, it could have been the grandmother, cousin, it was whoever the woman felt was their support person, and we would support them through the journey. We did assessments. So assessments were done at baseline, 2 weeks, 1 month, 3 months, and 1 month postpartum. So these assessments were done based on the smoking status, behaviour and history, and mental health. So with these baselines, there were also incentives. So we were able to give out gift cards. And I found that was a really key drive too, for people to look at their smoking behaviour. So I can't remember the exact values, but, you know, baseline was $25. So they would get incentives. So the woman would get the incentive as well as the significant others. And, you know, they were extremely grateful for that. And that was a real drive for them to want to change their behaviour, smoking behaviour. So our program had kind of a 3-tier approach. So obviously the smoking cessation support and advice. We also did case management, which was part of my role, and that was really intensive case management. And we also had an arts program associated with the ESF program. So the smoking cessation support and advice, so that was tended to be the entry point. So often the women would get referred to us when they came to the doctors for their antenatal appointment. We tried to capture them in their first appointment with the doctor. We'd ask about their smoking history, and from that, participants were asked if they wanted to join the ESF program. So at the time, realising that sometimes smoking is not the first priority, which is okay. There was never any pressure to quit or change their behaviour, but we constantly just kept it on the agenda, because often the feedback we got from women from other programs that they had been involved in is that they felt pressure to quit. And definitely when I delivered ESF, it's important to look at your smoking and trying to change your behaviour and quit, but it's in your own time. And that was the real key, is not making women feel guilty for smoking during pregnancy, but let's help to address the stresses that are causing them to smoke, which is the key when you deliver it within a Indigenous health context. We offered them free NRT. So that was the patches, the gum, the inhaler, whatever they needed. We made sure that the participant and the significant others, as well as other family members within the household that wanted to quit, we would also be able to give them free NRT, because I think when you work in Indigenous health, you know, there's often large families. So if we can support anyone within the family and in the house to change behaviour, then that was a great outcome. The smokalyzer was also used to determine carbon monoxide readings, and that was a real drive for the women to see their numbers go down. It was a real good time to celebrate the changes that they had made, even though they had all these other stresses going on. To see that they were actually changing their behaviour and wanting to reduce their smoking was a real celebration. So a smokalyzer was a really good drive for women and significant others to want to keep going. As I said before, they had financial incentives for quitting or even just reducing, was a real celebration. And like I said, all celebrations, you know, all successes were celebrated. And I think that's the real key when you've got so much trauma and stuff going on in your life, any little small changes, that's a good time to celebrate. And as one ESF client said, they were willing to work with me and not pressure me about giving up. You can just slow down in time. And I thought that was good, yeah, because a lot of people just expect you to quit straight up, not just like want to work with you. But we just talked a lot, just little things like that to avoid smoking. And over time, I have cut down heaps. And that was the key. It was just about yarning with the women and allowing them to hold the power, allowing them to decide when they actually wanted to quit or reduce their smoking. And often a lot was just about yarning, about their trauma, about their past history, and just helping them to address those stresses really helped to get smoking on the agenda. So case management, I think it's fundamental. You have to have a holistic, flexible approach. I think I find within mainstream services, you know, smoking can just be isolated as one thing, but in an Indigenous health context, you have to have a holistic approach. You have to see the person as whole, and you have to go on the journey with them. It's easy enough for me to say, hey, give up smoking, here goes some patches, but you actually have to get to know the person and actually go on the journey with them, helping them with Centrelink, domestic violence, drug and alcohol abuse. You know, we try to make it like a one-stop shop here, and we always ensure that it's participant-led. I can't put what I think needs to be done. It needs to be led by the participant, which was key. And it's fundamental to have that therapeutic relationship. I think trust is the key. When you work in Indigenous health, I found as a white woman, they'll know straight away whether or not they can trust you or not. So it's really important you be genuine, honest and respectful, and just build that trusting relationship is key, because I still get women coming back from 2 years ago. So, you know that you're doing your job right if they're able to come back to you. And also recognise the women's existing strengths. I think the women that I've worked with have been through enormous trauma that you just can't even imagine, but knowing that they have so much strength and resilience is what I really talk to them about the positives that they have within themselves, because they have so much self-doubt and low self-esteem that we need to really build their strength. And support and advocacy was provided to the participant. So that was huge. So whether that's around housing, Centrelink, especially around child safety, was a huge, huge issue within this community and the women I worked with. So just having that strong advocacy for the women and almost being their voice when they feel like they're not heard, and always trying to keep that smoking on the agenda was my goal, was to always just keep pushing smoking. As another ESF client said, everything really, it has helped with everything that I have asked and needed. And I'm so happy and grateful because my smoking, my health has improved because I've reduced. My housing is on track. I'm getting somewhere and actually feeling better about myself with the support and help from this organisation. And I think that was key, that we had to take a holistic approach. And once you've got a house, once you've got food, there's simple things in life, you actually start to feel better about yourself. So yeah, that was one learning. So the arts program, that was, so we employed a local Aboriginal artist, and what she did is she did some belly painting. So at around the 36-week to 38-week mark, women were, if they wanted to, were able to have their bellies painted in Aboriginal and or Torres Strait Islander artwork. And we also did photos, we did pregnancy photos, family photos, newborn photos. And I think it was really beautiful to see women actually enjoying their pregnancy. They had so much drama going on in their life that when we actually took them out of that environment and focused on them and baby, you could really see mother and baby actually doing that connection, that bonding. It was a really beautiful moment, seeing the women actually just embracing being pregnant. And this is what one ESF client had said, more in love with my baby, yep. It made me feel so good. I never felt so good in all 3 pregnancies. I was so glowing and everything with my third, and just doing this program. So this was a woman who during her other pregnancies didn't really connect with baby, and she was able to have some time to herself while we did the arts program, and we did some beautiful family photos, and she said she never felt so beautiful. So I think the arts program was really good to do with these women. So I'm not going to focus too much on the numbers because I think this research was really focused on the outcomes we got with these women. So we had a total of 25 Aboriginal and/or Torres Strait Islander pregnant women recruited, and significant others, there was 13. So I think the key to remember for this, the criteria was that the baby had to be Aboriginal and/or Torres Strait. So that was some of the outcomes we had. So we did have non-Indigenous women participate in this program, but they're not reflected on this graph. So the thing about the changing and smoking status, I think what we really want to highlight is that most women and significant others had a reduction in their smoking behaviour, which is key, because I think when you're trying to address smoking within an Indigenous context, as long as they're at least attempting to try to reduce is better than nothing. I mean, even changing behaviours, simple things of not smoking in the house anymore, changing their t-shirt when they hold baby, little things like that is little successes that we need to celebrate. So even though we didn't get high numbers around quitting, I think the fact that these people, the women and significant others, were willing to reduce and change their behaviour is a great outcome. Some of the ESF key features of value. So we ensured that it was always participant-led. It was relationship-based, so we really needed that trust from the women and significant others. We had that holistic approach, so we didn't just address smoking by itself, but we took the holistic approach, especially around mental health. And we also ensured that we looked after the whole family, not just the individual woman. We tried to take care of the whole family. Flexible, so, you know, we didn't kind of have strict guidelines we had to follow. We were pretty flexible in how we delivered the program. The caseworkers did a lot of home visits, just outreach in community. We weren't barely in the office. We were always out and about in community. And as I've been speaking about, it was a real strength-based approach, and it was definitely family-centred. So some of the key learnings during the research phase, I think the numbers have gotten higher definitely since the research, but we were able to get 5 participants into stable and appropriate housing. And I don't know if anyone's dealt with housing, but it can be a nightmare, and the wait list is huge. And many of our women in the community with children are either mostly couch surfing, and there's a lot of overcrowding. So to be able to get at least 5 of our families in stable environment and good housing is a great outcome. Participants were supported to access furniture and basic supplies. So we really did everything we could to set these women up. We were able to use Give It, St. Vinny's and local organisations to get these women set up in their own homes. We supported the participants with, you know, Department of Justice, child safety, social services, housing, anything the women wanted support with, we would do. And I think, unfortunately, child safety was a big one. We had to often, advocate strongly for them, housing and Centrelink and all that. And we'd also support the women with any antenatal appointments. We tried to be a one-stop shop. So if they needed to get to an ultrasound, we would come with them. If they didn't understand what the doctor or midwife was saying, we'd be there to help and support them. So every step of the way, we were with them on the journey. So I just would like to acknowledge the participants and their families, the Inala Community Jury for the Aboriginal and Torres Strait Islander Health Research. So prior to doing this research, we had to get approval from the community jury that we have set up here at the Centre of Excellence. The advisory group would like to thank the TIS funding who provided us with this grant, and the ESF team. So Deb Askew and Sonia and Jill and Viv and everyone else there. So we'd just like to acknowledge them as well with this research. So I guess it's important to understand that this research was done, you know, for about 14 months, and as an outcome, we were able to implement it into the service, which I'll talk about in a moment. But I just wanted to highlight the complex trauma that happens within the Indigenous context, and that intergenerational trauma is huge, which Michelle will speak about in a moment, but it really looks back at history. You can't work in Indigenous health or Indigenous context without knowing the true history since 1788. And that's something that I'm always have in my forefront when working with these women. The drug and alcohol dependence, so it's really knowing how drugs and alcohol impact in an Indigenous context. Housing, food insecurity was a big one. A lot of women were real shame about asking for food, but we soon recognised that it was a priority and we needed to start addressing this. So as a service, we've been able to implement strategies around food insecurity and be able to give our community food when needed. There was a lot of child safety involvement, as I've spoken about. Domestic violence, in particular family and relationship violence, was huge, and often these women were extremely reluctant to go through domestic violence, DV Connect, which I understand and I get. So that was our role, to help these women to feel empowered to escape domestic violence. And often they didn't trust services, so they wouldn't go to other services to get that kind of support. So that was kind of our role as caseworkers, to do that for them. They put a lot of trust in us, and yeah, I'm honoured that they trusted in us to do that. There was a lot of family breakdown. I guess just acknowledging the trauma, the childhood and the adult abuse that these women have gone through. And often 9 times out of 10, they hadn't spoken to anyone about it. So as a caseworker, they saw us as someone that they trusted. So they would talk to us about their trauma in their childhood, which was pretty huge. And that's why I admire these women for the strength that they have to be here still today, fighting strong. And obviously with all this complex issues, their mental health was a huge one. Often women, the women I helped, would talk about suicide. To them, that was the only way out. But you've always got to go back to the positives, and, you've got these beautiful kids and you've got to stay strong. You've been through hard stuff, but you've got to be strong. So mental health was a huge one. The anxiety, depression, every woman would suffer, and suicide was always their go-to. So often when they'd feel suicidal, they'd ring me up or the other caseworker and go, hey, I need to have a Yanti, I'm not feeling right. So and then that's why we were able to link in with Michelle as well. And systemic racism, which Michelle will cover later on, but that's a huge one, trying to get your head around how the systems are set up. And unfortunately, I've seen it with our Aboriginal women when I'd advocate for them. Just some of the racism and the stereotypes that would come through from other workers was really hard to see. So I really use my my knowledge to challenge some of those racist views. Just wanted to share a video with you. I think you need to understand the intergenerational trauma. So I'll just share this video.
The story of our communities, people and nation starts a long, long time ago. More than 60,000 years, in fact. This was when our culture and our law first started to thrive. We knew who we were and where we belonged. We took care of each other, our land and our waters. We ate food that made us healthy, lived on country and abided by our laws and song lines. Our families, our children were happy, with strong minds and hearts, because they were where they belonged. But then, everything changed.
Colonisation came, bringing wars, disease, famine, violence, and the destruction and violation of our cultural laws, sacred sites, families, and communities.
We were denied our knowledge, language, ceremonies, and identity, the very things that tell us who we are and where we belong. And our connections with each other and the land grew weak.
And then our children were taken from us. They had their names changed and their identities stripped away. They were told that Aboriginal people were bad. Worse still, they were told that their parents and grandparents did not want them.
For years this happened, and those children became known as the stolen generations.
Our children were denied love and experienced physical, emotional, and sexual abuse. This left very deep, very complex, and very real wounds, leaving scars that are still being felt personally, socially, spiritually, and collectively.
In the time when our story started, we were able to parent in the cultural way that has seen our families survive and thrive for generations. Our people were strong, and our culture flowed and healed us in times of hurt.
But since the trauma of colonisation and the stolen generations, we have not been able to heal in the same way. And we have unknowingly passed this trauma on to our children through sharing our sad stories and having them witness and experience our pain. This is known as intergenerational trauma, and we see symptoms today in broken relationships, disconnected families, violence, suicide, and drug and alcohol abuse.
But this is not where our story ends. We still have strong minds and hearts, and we still know who we were and where we belong. By creating safe and strong communities together, supporting our families to be free from pain, returning to our culture and building a strength of identity, we can stop the cycle of trauma and bring about positive intergenerational change so that we can continue to thrive for the next 60,000 years. There are simple things that we can all do to help heal our trauma.
Visit healingfoundation.org.au to find out more.
So I think it's really important to realise that the strength and resilience that Aboriginal and Torres Strait Islander people have. I know from my experience working in Indigenous health that often they speak about wanting to break the patterns. I can think of one woman in particular who comes from a family, a strong family, but unfortunately has had impact of colonisation, and a lot of her family is on ice, in particular her mum, her sister, her auntie, her dad. So she's surrounded by ice use. And I guess for her, she expressed real strength in wanting to break those patterns, even though everything's up and against her and she's stereotyped as an Aboriginal woman. You know, she's trying hard to break those patterns. So I think there's a lot of strength within Aboriginal women that I've definitely worked with. And even though they've got all these complex issues and, you know, systems aren't set up properly, that there's still strength within the family and 100% strength within this community as well, where they will support each other in times of need. You know, there's so much strength there. And having that strong identity on who you are and that reconnection to culture is fundamental. It builds their strength, their spirit, and helps them to kind of be settled and be as one. And I think it's really important to have an Indigenous approach to healing. It needs to be culturally safe and culturally appropriate. And sometimes, you know, the Western approach doesn't always fit within an Aboriginal context, and acknowledging that and allowing the non-Western approach to come forward, especially in an Aboriginal context. So I'm going to hand over to Michelle to talk about trauma-informed care.
Yeah, so I guess if anyone's caught the couple of other talks that I've done before with Insight, I have covered this, but it's relevant for this work as well, just because, like Leigh-Anne said, this program started basically with the primary focus on smoking cessation for young pregnant women. And, you know, being the psychologist working in the same service, I wasn't really included in the research aspect of things from the beginning because everyone, well, I guess the people in charge didn't think that it would be relevant. And it was only after months of the work being underway and the project was in full swing when we realised that there was a lot of trauma and a lot of mental health coming up with the clients and their families. So Leigh-Anne and the other case managers involved actually had to become mental health case managers overnight, and we had to do a lot of really quick learning and education about how to handle people with the symptoms of complex trauma and all the other mental health presentations that we were coming across, and then it all got included from them. The trauma-informed care, as in the research team, basically stems from the trauma-informed care resources that we put out through Metro South Mental Health and Addictions last year through my other team, the Way Forward Indigenous Mental Health and Addictions team. So the types of trauma that we would commonly come across that are also listed in the, I've got a copy of the trauma-informed care guidelines, which you can access. I've got all electronic versions. If anyone wants to contact, I can send those out. That's free for anyone to use. But basically the main types of trauma we come across is the intergenerational that you just saw in the Healing Foundation video, the transgenerational, which is more of the inherited emotional dysregulation and the kinds of things that can be actually picked up in your DNA, but you know, trying to keep that strengths focus. There is also the resilience that's passed on and inherited. So other types are single event traumas. So, you know, Leigh-Anne mentioned things like domestic violence and drug and alcohol abuse and, you know, living in unstable families and communities, and, you know, those kinds of environments usually do lead to incidents of single event trauma, which could even include things like, you know, sexual abuse, rape, being in bad car accidents, any of those really high risk situations that unfortunately a lot of clients involved in ESF have also experienced, or their family or people close to them have, which kind of affects them vicariously. And then the complex trauma, that's the main type we like to try and consider, because, you know, being an Aboriginal psychologist working with primarily Indigenous clients now for about 15 years, I have seen a lot of complex trauma in our population, and I can see, you know, where it comes from. So it all makes sense to me. But at the same time, we still haven't really come up systemically with a really good way of dealing with that, because, you know, as most of you would know, complex trauma is not acknowledged as an Axis 1 diagnosis at the moment. There are pushes for it to happen one day, but it hasn't happened yet. And there's also no really clear or quick treatment for it. So, you know, it involves a lot of long-term therapy, lots of intensive support, which is all very resource intensive. So I suppose there's a lot of reasons why the government and different health people in power wouldn't want that to be part of our core work. So what that leaves us with is a lot of people from community, especially Aboriginal and Torres Strait Islander people, who present with symptoms that can be misinterpreted as personality disorders. And usually the ones that people don't want to deal with. So antisocial and borderline are probably the two main diagnoses that get thrown around. And most of the time when you get to know people like we do, it's actually not those scenarios that's happening for them. It's a lifetime of lots of different types of trauma, a lack of support, and a lack of education and coping strategies in how to deal with it and how to break those cycles. So that's something that we're hoping that we have already achieved at least a little bit with ESF and with other work that we do around the service, but it's a long-term problem and definitely going to be something that we're all working on for a long time to come. Can you do the next one? So yeah, as I was saying, what it can look like is difficult behaviour. We often get reports from people presenting for help, especially in emergency departments or by contacting police and ambulance, where they end up getting taken to the watch house or charged, put in some sort of trouble, you know, and at the very least turned away from hospital because people see it as being manipulation and throwing tantrums to get what they want, which, you know, in my mind, is actually a reflection of how desperate people get for help when things get too much. And, you know, the resilience lets us put up with things for a long time before we get to that breaking point. And then unfortunately, it doesn't feel good or look good when you reach out for help. So, and, you know, like I said, there's no quick fix or treatment for complex trauma. So people don't really want to have to deal with that. It's much easier to say, if you're showing up to a mental health emergency department and you look like you're throwing tantrums and trying to get benzos or something like that to calm you down, then we're going to say you've got drug problems and you need to go and get drug and alcohol help first and then come back. You know, it's a very common story, and unfortunately it still happens now. And then, you know, the flow-on effect from that is that people from community don't want to get help. So they will just try to live with it, try to cope with it the best they can at home, which usually leads to more self-medicating and, you know, common practices of self-harm, really risky behaviour, lots of things that are reminiscent of borderline personality and bipolar. So those things do get very confused, but it's really not that. It's more to do with them just not having any appropriate help or any, you know, culturally safe and supportive context to reach out to. So our program has been very successful here. And as Leigh-Anne said, a lot of the girls and, you know, their families and anyone associated will come back years later, even after the babies are all grown up, and they'll still be coming looking for support if things get bad, because they know they feel safe and they feel supported, which we think is a testament to all the hard work that Leigh-Anne and her colleagues have done. And, you know, for the most part, I don't actually have to see a lot of these clients because they feel so safe and comfortable with Leigh-Anne that they would rather just work with her. And, you know, that suits me just fine because I have plenty of other people to see. But that also put a lot of pressure on Leigh-Anne and the other case managers to have to learn how to work with people like that very, very quickly and get very good at it overnight pretty much. So yeah, we've all had a very steep learning curve, but I think it's worked out well. And the other, well, I guess building on what we mentioned before with the impact of systemic racism, we have actually had a little bit more research and support from policies in the last year or so, starting to acknowledge the fact that racism can impact on Indigenous people in Australia as a trauma. And when you think about the systemic levels of racism and the things that we've seen, and, you know, Leigh-Anne's been witness to sitting with, whether it's child safety or housing or Centrelink, you know, core services that people have to access and they have to sit there and work with them, in the way that people get treated. It's actually disgusting, but it's also traumatizing for the people because they would rather starve, they'd rather live on the streets, they'd rather have no money than deal with people treating them like dirt. And I think that in the broader context of the fact that there's nowhere else to go, they can't call the police without fear of getting some sort of backhanded result where they end up getting in trouble instead of getting help, and bringing, you know, that negative spotlight onto their own family when that fear of child safety removing children is still very real, and we're still dealing with that threat all the time across the whole community, not just for ESF clients. So, you know, there's a big resistance to accessing major systems for help, just because it can often lead to bad outcomes for the people who actually need the help. So we're very conscious about the impact of racism, and I know it comes up a lot for me with clients just working as a psychologist here in the clinic too, where people get referred all the time for depression or anxiety or PTSD and lots of other things. And when I talk to them about what's impacting them the most, it usually comes back to daily racism. So it's really important for us to be conscious. And there's a really very, very new national scheme that just came out like a month or so ago. So that's the second one we've got listed there, where the tagline is actually "No place for racism in healthcare," which we took as some really good support for what we've been saying for a while. And for any of you that might be aware too, Leigh-Anne and I are both facilitators for another program that we run, supported by Inala Indigenous Health and Metro South Mental Health and Addictions and Transcultural Mental Health as well, called Courageous Conversations About Race. And that's all for, you know, health staff to start being more conscious about their own personal biases and behaviour and how we treat people as a system, so we can try and work on improving that, at least in the health space, if not broader. So we're really proud of that work, and we're hoping to continue that for as long as we can. So as I mentioned before, the resources that we developed last year, they are freely available now, so you can just contact through the Way Forward email address and I can email those back to anyone who wants them. We have the bigger guidelines, which has a lot more information in it. And we also have a smaller poster or pamphlet version that you can fold up and hand out to people or just keep it for yourself, as well as it's more of a mental health client journey of, you know, with trauma-informed care versus without. But, you know, I think anyone working in the addiction space, I mean, for Indigenous people, it's all the same. We're very much about holistic care, and that, you know, it's very hard to tease apart whether it's physical health, mental health, spiritual health, and cultural connections and all those things. You know, if you've seen the social emotional wellbeing model of holistic care, if you haven't, you should look it up because it's very handy for understanding how Indigenous health works in general. So for us, we don't really treat those things as two separate entities, it's all the same. You know, you need to cover all those bases for people to be well, you know, in the best sense of the word. So that's the brochure or pamphlet, whatever you want to call it. The two sides of that. The front of the guidelines, and I didn't include the patient journey, but you can access it if you know, if anyone wants it, just email. I'm happy to share it around.
So where is ESF today? So with the research that was done, we were lucky enough for Centre of Excellence to actually continue to fund 2 caseworkers. So the other one that was my co-worker was Melissa Dunbar, but unfortunately we weren't able to continue her funding. So at the moment, we still have myself, who's the caseworker. So that's great that we've been able to embed ESF within the service. I think it's a important service that we have within the community, supporting our families. So we're trying hard to fight for another caseworker, because at the moment it's, you know, I've got 14 women or 14 families on my caseload, but just understanding that these are very complex clients, and a lot of the clients, drug and alcohol, child safety, housing is a big one, trauma, mental health. So they're quite complex clients, as well as putting smoking on the agenda with all that going on can be a real challenge. So, you know, even though there's, you know, it may look like low numbers, only 14 families, but often you're helping other people within that family. So I'm pushing hard to try and get another caseworker, because at the moment it's a bit too much. But over the past 3 years, so since we've been doing the ESF research and we've been able to embed this program within the service, we've been able to assist 53 families in the Inala community. And as I spoke about, I still get women from 3 years ago coming in wanting to have a yarn, hey, you know, and just to see baby and see how well they're doing is really rewarding as a caseworker, because often, you know, it is a hard job. It is emotional. You know, you're there with the women, you build that emotional connection with them that you'll sit there and cry with them when they're talking about suicide. So it's really beautiful to see when they do come back in and they're looking amazing, you know, they're doing well. But then there is a flip side where some women have, unfortunately, lost their children to child safety, or have, you know, taken up ICE quite heavily. So there is, you know, kind of the flip side to it all, but I'm always there for them and always willing to support them. And I think that's the key is, I don't turn my back. I'm always arms open if they ever need anything, you know. So we assist with anything, housing, transfer, finding accommodation, escaping DV is a big one, addressing past trauma, you know, really addressing their mental health. I think a lot of the women are ashamed about talking about their mental health. So it's been really good having Michelle here, and the women trust me. So then I'm able to get them into Michelle, because I know, you know, Michelle's an awesome Aboriginal psychologist. So by them having the trust in me, I'm able to kind of address those barriers of actually coming to see a psychologist. And once they meet Michelle, they're like, oh yeah, she's cool, I like her. So it's kind of that stigma that, oh, I'm too ashamed to go see a psychologist. But once they start to meet her, you know, the barriers are broken down. So through my relationship, I really try and encourage and support the women to seek, you know, whether it's a drug and alcohol worker, linking in with, you know, Michelle here. And I think that's the real key about ESF and working within the Centre of Excellence, is it's a multidisciplinary team. So we're able to utilize, you know, it's like a one-stop shop. You know, we've got a psychiatrist, a psychologist, a social worker, caseworkers, you know, we've got everything here. So it's a real awesome service to work within. And that's been a real key. So I was just going to briefly just go over a few of the cases I have. So Lisa's obviously not the real name, is a 23-year-old single mum of 3. Her family includes members of the stolen generation, and this has impacted on the whole extended family up to and including today. The ways that this has impacted is on the breakdown of family and cultural connections. I guess looking at history, you know, when the white people came to Australia back in 1788, you know, the land was stolen, the culture was taken, the language was taken, the children were removed. And even though you hear it happened way back in 1788, it still impacts Aboriginal people today, and you need to acknowledge that, and you need to understand that history and how it impacts Aboriginal people today, because it's often passed down through the generations, you know, which impacts the parenting practices. Some of the women I've worked with speak about, I don't know how to be a mum. I never had a mum, or I never had a dad. So it's really challenging for them to actually step into a role if they haven't been mothered or parented themselves, which is a real challenge. Mm-hmm. And just that, you know, the trauma that these women have been through, they have so much strength within themselves that they inspire me, you know, like they've gone through so much, you can't even imagine that they're still here, they're still fighting, they're still standing. And that's what I try and build upon when working with them. And, you know, as a result, as you know, of trauma, it does bring unhealthy learnt coping strategies. So, you know, I do see a lot of the women, some of the women using ice, you know, Yandi or marijuana is a big one. And it's often within the family as well. So mum, auntie, uncle, cousin. So I guess to try and get smoking on the agenda can be a real challenge. And often they'll go to smoking when they're stressing out, because it's, you know, how they release their stress. So, you know, you've got to really start from the top and try and make smoking a priority. And I guess all this does impact the social and emotional well-being, which includes the physical wealth, the mental, and especially the spiritual, and the connection to country and culture has really impacted the women I worked with. They often talk about wanting to reconnect with their culture, but there's so much going on, they don't know how to do it. And as Michelle spoke about systemic racism, and I've witnessed, been in DOCS meetings, been with Housing and Centrelink, and actually seen the systemic racism that exists. And that's, you know, in one particular woman has just had enough. So she's sick of speaking up. So she'll often come to me and ask me to kind of speak up and start to address some of that systemic racism that exists. And I will speak up, and I will, you know, I have pulled up housing for the way they've mistreated some of our Aboriginal women. So yeah, I do use that to my advantage. And, you know, unfortunately there is DOCS involvement, and I've had, you know, that's another system that's built on racism, but won't go into that too much. And we also address food insecurity, because that's a huge one. Even just the simple things as bread, milk, can, you know, I do stuff in nappies and formula and things like that. She suffered from domestic violence and low self-esteem. So they were some of the kind of the challenges that she had, that I had to try and help go on the journey. I walk alongside these women and go on the journey with them, never in front. So some of the things we're able to do was able to assist her with housing. We had heaps of advocacy around housing, getting support letters in, and just constantly at housing all the time. We were able to support her with, you know, the lawyers in the courts, and advocacy for child safety, linking into psychologists, and helping her develop her low self-esteem. She actually needed a lot of work on her teeth, and it took us about 18 months to get to where she is today with her teeth, and she now feels so beautiful and is able to smile and feel good within herself. So I know it's only little steps, but it's such a huge impact on one woman. And there was a lot of support around, she had a lot of suicidal thoughts. So yarning with her and trying to build her strength, and obviously linking into appropriate services when necessary. She had a lot of guilt, she had a lot of past trauma, and she would often use drug and alcohol to deal with that. So just trying to build in other strategies. And one thing we did do with ESF is look for other strategies to cope with that trauma. So whether it was about, we would give them journals and give them books so they could write stuff down. We would give them art stuff so they could go home, and when they're feeling down or low, they could actually do some colouring in. As simple as it is, it actually helped women to, you know, use other strategies as opposed to smoking yandi or drinking. You know, even going for walks, listening to music, just trying to identify what their strategies could be. And, you know, I assisted this woman a few times to escape DV, because often they don't have trust in mainstream services. So we were kind of the one-stop shop. So, you know, I know we don't have huge numbers, but we do a lot of intensive casework with these women. Yeah, should I go into the phone? I might just wrap it up. I mean, that was another case study we did, just in case there's any questions. I'm realising off the time. So I might hand it over, and yeah, thank you all for joining. And if you have any questions, then yeah. please feel free.
Wow, thanks, ladies. Michelle and Leigh-Anne, what can I say? What a really excellent presentation. And normally I'm busy writing lots of questions myself, but I was just so engaged with your presentation that I haven't written too many down. I've got some from some people that have written in. But the one thing I want to say is listening to you, and the thing that engaged me is the passion of the two people that are presenting today and their love for the community that they're working with. And, you know, I know of the services that you do at Inala, but it just blows me away when I just hear about the flexibility of your approach in working with these people. And I particularly like the one of the last phrases you said, Leigh-Anne, which is that you never walk in front, that you always walk alongside. And just that approach, it kind of touches me. So I apologise if I don't have loads of questions for you, but as I say, it was wrapped with your passion. And not just me either. Many people love the inclusive approach of the family that you did. You know, it wasn't just the individual that walks through the door. You want to engage the whole family. In fact, you want to engage the whole community. And almost smoking, although that was the initial focus of the research, actually almost became, you know, kind of a back burner thing. And it was actually about building that person and, as you say, empowering the strengths that those people already have, but often don't even realise that they're carrying with them. You know, the things that these people have gone through and survived, you know, even the racism that's still going on today, you know, to tolerate and still strive and still try to do the best you can. Just amazing. So thank you very much for that. Somebody from, and I apologise because I don't know all of the areas in Australia, so I'm probably going to say this wrong, from Woorabinda. So we had a Woorabinda worker who's written in, who works in community corrections, and again just highlighting that importance of developing that rapport with the individuals that walk through your door to make them feel that they're safe and that you're not just judging and, you know, and kind of demanding a change from that person, but really working with what their goals would be. So again, thank you very much for that. And also I thank you for your patience when we had that little issue with the video. Many people have written in and said how much that video touched their heart, and, you know, every time I watch that, it kind of, and this isn't, you know, it kind of makes me feel ashamed, but it also makes me feel passion for the people that we're working with. So thank you very much for sharing that. I do have some questions. So one of them that's come in is, were many of the women that you were engaged with, were they polysubstance users? So was there other substances being used? And even though it wasn't part of the research process, did you see anecdotally any changes in behaviours around other aspects regarding that in the process of doing this project?
So I think, yeah, there's definitely poly drug use. So a lot of the women, you know, did drink alcohols, and definitely Yandi was a big one. There were a few that did continue to use ice, but, you know, through the support of our service, we were able to get them not using ice as much, and just really to look at their changing their behaviour.
Yeah.
Yeah, I think we did notice that those things improved because, like we mentioned before, with the holistic approach to care and health, that, you know, working on any aspects tended to have a positive influence on the rest of the aspects of someone's life anyway.
Yeah.
You know, even harking back to the stuff about self-esteem, getting a big focus throughout there, and the bonding between mother and child, even while the child was still inside. A lot of that stuff had a really positive influence and flow-on effect that wasn't really planned for, wasn't really measured in the research, but definitely noticeable.
Yeah, thank you.
Yeah.
You also mentioned kind of midway through, which is really disheartening to hear, that racism still exists even amongst what we might call professional workers that, you know, are supposed to be there supporting and, you know, assisting these people. And, you know, it's something that we encounter periodically, but it's actually a difficult thing to challenge when you hear things like that. So can I ask if you have any advice, if you hear, and I know it's probably $1 million question, but if you hear that sort of thing whilst you're engaged with other services, how would you encourage a clinician, a support worker that's, you know, with someone? Because often the person we're working with doesn't have that confidence and that strength to speak out about it, and it is our role to, you know, we have to own it ourselves.
I think advocacy is a really big part of all the work for all of us here at the whole Centre of Excellence. We all, I guess you end up doing a lot of advocating for your clients because of that. People not feeling either safe or comfortable or feeling the fear of backlash. You know, if you need something from that service, you're not going to really want to go off at them. But then we have had clients who do go off sometimes, and then they do suffer the consequences. So I guess we're lucky for Leigh-Anne and I in the sense that we do the Courageous Conversations About Race training, which is all about teaching tools for how to address and how to have conversations about racism. So we actually, you know, remind each other often and try to use those tools and practice them as much as we can ourselves, because it does work out to be much more effective rather than just going into bat and arguing with people, because that doesn't really get you anywhere, even if it's professional to professional.
Sure.
So yeah, I think that's one of the main things we've had lots of
training you mentioned. What was that? What was that training you mentioned again?
It's called Courageous Conversations About Race Beyond Diversity, and it's a 2-day workshop that we've been running along with 2 other women in Metro South. About 18 months now we've been doing that work, you know, mostly just for health professionals, a few other guests here and there, but, you know, for mental health and addiction staff for the most part. And really it's just, you know, people that want to try and stop being part of those systems that we want to, you know, a lot of it's unconscious bias and a lot of it's, you know, really, you know, buried prejudices and misinformation. You know, people just don't know what they don't know, and they believe stereotypes and, you know, kind of act accordingly. So part of our work is teaching people how to fill those gaps of knowledge and how to treat people as an equal. And you would have heard Leigh-Anne mention a lot in her talk how she's essentially, you know, very non-judgmental and sees the clients as equal. So she's not looking down on them or seeing them as someone, you know, that you pity. They're all equal. And I think that's a big part of the relationship and the safety that they build, is that they feel like they're respected.
I agree 100%. And actually, I know, you know, obviously this has an Indigenous focus, but I think my passion is that we should treat all of our clients like this. It doesn't matter
Totally
what their backgrounds are. We're all equal.
Well, Leigh-Anne's had non-Indigenous mums in the program. Yeah. Yeah. And everyone appreciates that approach.
I think it comes from that. It comes from that. You know, I'm a kind of a fan of people like Gabriel Marte, who I'm sure you've probably heard of, who's, you know, a big trauma specialist, and it's very much not about why the drug use, but why the pain, and getting an understanding of the background of those people and what they've been through in order to be able to walk alongside them, as you so eloquently said, Leigh-Anne. So thank you for that. Another question that's come in, obviously the research project came to an end, but the engagement, I'm sure, has continued. Have the ladies that were involved, have they continued to work towards their goals and walk alongside you still?
Yeah, definitely. I mean, I still engage with women from, you know, when we first started the project, they still come to me for help, and I'm always there to support them. So yeah, it's still continuing on. I mean, yeah, still doing the work. The intensive case management doesn't end. So yeah, and still doing it.
Assuming as a result of, because, you know, the grapevine is a big thing, and word spreads very quickly. So I'm guessing that once they know that you're a safe place and somewhere that they can come to, I'm guessing it's not just them that comes, but you also find that your numbers will increase as a result.
Yes, I always get, oh, my cousin told me to come and see you, and, you know, so yeah, word of mouth. I mean, I've been here, you know, 16 years, so, you know, I'm kind of embedded in the service, but yeah, and I think the key is just being genuine, honest, respectful, and they'll soon know whether you're bullshit. Sorry. You know, and they judge you straight away. They know whether you're a genuine person or not. So, and I think that's where the passion comes into it. I'm passionate about Indigenous health, and yeah,
that definitely came across, Leigh-Anne, which is why I get excited. So thank you. And I think you've probably just answered the next question that I've got, which is clinicians are often out of their depth in doing cultural practice in therapy. What can they do to be authentic but effective helpers to the women? And I know you said genuineness, and I think that's definitely should underlie everything.
Yeah, I think for me, being a white person working in an Indigenous space is, I'm not no expert, you know, and I acknowledge that, and I'm forever learning. And I think the key is really having an open heart and an open mind, and really understanding the traumas that Aboriginal and Torres Strait Islander people have faced since 1788. You know, you've got to have that in-depth understanding of all the massacres that occurred, and why the women that I work with, I want to have an understanding as to why are you using ice, why are you know, and if you don't look at the past trauma, then you can't really kind of help to address the true core issues. So,
and I think on that,
that's kind of the space I take.
I would just add to that, and many people listening will know this, but in case they don't, this is why I want to add this, is one of the things that, you know, I'm obviously from London, so, you know, I'm not born and bred in Australia either. And one of the things that I've heard in my time in Australia is, yes, but that was a long time ago and we need to move forward.
Yeah.
And I think that one of the things that people don't realise is that trauma doesn't just affect that person as in their day-to-day life. It genetically changes the DNA makeup of that person, which is then passed on to future generations. So yes, you know, I'd love to be able to say, yes, we can move forward, but we still have to manage the trauma of the, you know, the families of the people of our past as such, because they're still carrying that, even if they weren't aware that they were carrying it at the time. Does that make sense?
That's right.
Yeah.
Totally. I actually spend a lot of time educating some of our clients, like across the board and including ESF, about Australian history, about, you know, why there's so much broken parenting practices and disrupted families and people feeling lost because they don't know which country they connect to. And when I teach any of our clients of all ages about this kind of stuff, it's like a light bulb goes off, and as sad as it and tragic as it is, it actually helps them put the pieces of the jigsaw puzzle together to go, oh, is that why we've got so many problems? Oh, that's why we're struggling. So it's not like we can just say, okay, since the referendum, we're all the same now. Let's all just forget about all that other stuff that happened before.
Definitely. And I think that understanding helps to relieve some of that burden they're carrying, some of that guilt that they're thinking, because people believe what they're told. And so, you know, if they're constantly told one thing, that's what they end up identifying as. And so when they get that education and understanding, it does help them change. So I agree completely. Listen, I don't have any other questions in front of me. I know, Leigh-Anne, you were quite nervous about presenting this prior to doing it today. That definitely wasn't evident today. You came across extremely well. And definitely the responses that we've got on the chat would highlight that. There's lots of thank yous and lots of appreciation. And I want to pass that on as well. As I say, I think Inala do fabulous work over there. And I want to thank you for giving your time to present for us with insight. So thank you very much indeed, ladies.